And start now?
Yeah.
Yeah. Good evening, everyone. So let me give a brief introduction about our keynote speaker, Dr. Imran Khan, for today. He is qualified in MDS oral and maxillofacial surgery and then done with his PhD. His academic achievements are he's very active in teaching for the last 17 years and he's currently working as a professor in the Department of OMFS Faculty of Dentistry, Jamia Millia Islamia, and he has served as a subject expert for Union Public Service Commission, as a subject expert for the State Public Service Commission, as a subject expert for the National Board of Examinations Medical Sciences. He has also worked as an examiner for AIMS, RUHS, RIMS, and Delhi University, and many other government as well as private universities. He's been invited as a keynote speaker for the national and state conferences, more than 35 publications in subject journals with 340 citations in index of 9 to 10 with an index of 8. He is also a member of the editorial board NJMS and he's also a reviewer in JOMSI, SARA, Annals of Maxillofacial Surgery, Alexandria Dental Journal, and he has 4 international patents. Not only this, but he also has served as an assistant dean students welfare for Jamia Millia Islamia and is currently the president of cricket for Jamia Millia Islamia University, and he is currently the honorary secretary for the AOMSI Delhi NCR state and has served as a past president of IDA Ghaziabad. So today we are privileged to gain the knowledge from his expertise as he presents this lecture on surgical skills, surgical principles for the general practitioner. Sir, can we start the presentation, please?
Thank you so much, Zaiba, and thank you. Sorry to intervene. I think
I am sorry for the glitch as well.
The wrong CV, I had to intervene. So I'm just putting my presentation on screen share right now. Just give me a second.
Yes, sir.
Is my screen visible, Zaiba and Dr.
Yes,
Gausia?
sir. Yes, sir.
Yeah, so warm greetings from the Faculty of Dentistry, Jamia Millia Islamia. First and foremost, let me thank Global Dental Professionals, Dr. Gausia, Zaiba, for having me for this informative talk. I would start my presentation with the publication in a British dental journal, which was in 2016, and not very good news actually. This says that there are too many dental graduates in India, and this states that more than 30,000 dental graduates are passing out every year, and many of them unfortunately are not able to find good jobs or good support system after they finish their graduation. But this is one consistent thing which is happening, that the colleges are increasing and then we have more and more dental surgeons coming out. So how do we find a solution to that? The Dental Council of India, now the National Dental Council as we call it, gave one statement in Times of India that we are now freezing on the new dental colleges all across, and but already we have around 309 institutions churning out around 26,000 dentists, and many of them are jobless. Okay, so what is the way to find a solution? Maybe we can, as the Dental Council thinks, maybe if we can just stop the new colleges, maybe yes. But the time taken for that maybe for a few decades. But what about the current scenario, where the current scenario looks like this, where this poor animal is actually burdened by this gentleman who is sitting and enjoying his ride. So the dental professionals are actually feeling overburdened because I interact with lots of dental graduates who are freshly passed out. Some of them come to me and say, sir, we are not getting enough remuneration of our services which we are giving, or we are not actually getting jobs, or the scene is not very good for us. So the gentleman here maybe represents the competition, the cost of running practice and inflation, whereas this poor animal here in my picture image represents a private practitioner trying to establish himself. Now, is there any possible solution? What I can suggest is, if a dental surgeon, if a graduate dental surgeon who is practicing general dentistry, if he or she can equip himself or herself with adequate knowledge, skills, and armamentarium to avoid over dependence, then maybe yes, because all the surgical procedures which are coming to their clinics or their referral or their centers, if the dental surgeons are able to perform those minor surgical procedures by themselves, then yes, probably they will avoid over dependence on those specialists. So basically, today my talk is basically on oral surgery for a general dental practitioner. And as Zaiba introduced me, I'm working in Faculty of Dentistry, Jamia Millia Islamia, and my email ID is also given there. Now, what are the routine oral surgical procedures that are under the scope of dental practitioners? Okay, I'm just going to talk about minor oral surgical procedures. I'm not talking about any major maxillofacial surgical procedures. Now, extractions and simple impactions, endodontic surgeries, INDs or incision of drainage of abscesses of simple nature, alveolar recontouring procedures, dental implants, managing simple and traumatic injuries involving teeth and dentition, diagnosis and treatment of pathological and pre-malignant conditions of the oral mucosa and bone, and diagnosis and timely referral of oral malignancies, orofacial pain and management, and managing medical emergencies on the dental chair. So these are basically some of the procedures which can be performed easily on a dental chair by dental practitioners, and we'll be talking about some of them, not all of them, some of them. I would start my presentation by quoting Sir William Castley Fry. He has famously said that God gave you ears, eyes, and hands and use them on the patient in that order. That means you listen to the patient well, you examine the patient, and then you operate. You listen to the patient, patient probably is giving you the diagnosis. Now, for any enthusiastic dental surgeon who wants to practice oral surgery, there should be some basic equipments which are required for any surgical setting. Okay, sphygmomanometer, a basic pulse oximeter, maybe 2 para or 3 para, an oxygen mask and cylinder. These are very, very important to have in your operatory. Okay, don't think that these, I may require it once in a blue moon, so let's not have it. These are life-saving equipments. These are equipments which will show the vitals. Okay, show, and once you may require it maybe in a year, but that may be very important for you for that time. So it is essential to have these equipments. Plus, you also need to have an emergency drugs kit. It is absolutely important. I always teach my students, my residents, that you always have an emergency drug kit available at your at your practice, at your referral centers, at your clinics, at your setups, and that should have injections like adrenaline, atropine, hydrocortisone, which is a steroid, dextrose, salbutamol, inotropes. You should also have glyceryl trinitrate, and you should also have injection avil and ethiamycilate. So these are basic injections or the emergency drug kits that you should at least have. And please make sure that you are checking the expiry kits, because I've known cases where people have kept these emergency drugs for years, maybe 4 or 5 years, not used them. And once in a blue moon, like a patient was right there and they wanted to give an injection of hydrocortisone, but that injection was, of expired date. So please check your indent and have it, and always review those emergency drug kit that you have. Specialized surgical instruments may be required for minor oral surgeries, such as scalpel, periosteal elevators, curettes, hemostats, mouth gags, chisel, suturing kit, mastoid suction tips, surgical burrs, etc., etc. So these are basic essentials of any oral surgery practice. For a general dental practitioner who is planning to have surgery at his workplace, you should equip yourself with these instruments. Now, getting prepared. Uh, Many of the patients which are indicated for surgery, which we operate upon, we generally need to investigate few basic investigations. Okay, even for a small biopsy or maybe a third molar surgery or a minor surgery, make sure that you have a complete blood count or a BT or a CT for that patient. It is absolutely essential. And then you should also know to write what radiographs are required to diagnose certain situations, and you should also know how to read them. Okay, sometimes you may also have to pre-medicate the patient, especially if a patient knows that tomorrow or day after tomorrow I may require a surgery and I have been appointed a surgical appointment. Patient might be too stressed out, so pre-medication sometimes, pre-medications like alprazolam, or any drug which is uh, which acts as a tranquilizer for a patient, can help patient prepared for a surgery. Informed written consent is absolutely essential these days. Don't think that it is only essential in Western countries. In India also, it is absolutely important to have, and you maintain that informed written consent, and then how you prepare the patient. As I told you, hematological investigations like CBC, BT, absolutely essential. In patients who are on anticoagulants, many of the patients right now which we treat are taking ecosprin or clopidogrel, a common antiplatelet drugs that cardiologists or physicians prescribe. Okay, so it is essential that you have this basic INR, PTT, APTT done for them. Okay, and I have heard many a times a dental surgeon speaking and asking the patient, okay, you stop ecosprin, you stop clopidogrel 2 days before, and we'll do the extraction or the minor surgery. What I would have to say is, you have to, in general, you have to refer these patients to the cardiologist and the physician back to the physician or the cardiologist. Let the cardiologist write it on his letterhead, or the physician write it on the letterhead, because sometimes there might be chances that the patient may have a condition which can actually, stopping ecosprin or clopidogrel can actually precipitate a cardiac event. So it is better not to do from your side. You ask your physician, you ask the cardiologist to write it, or with his consent, then do it. That I would advise. Okay, don't just say, okay, you stop for 2 days and then I'll do it. Because cardiologist or the physician is the best person to manage this. This is what I teach my students as well. Uh, many a times, yes, of course, blood sugar levels, India unfortunately is the diabetic capital right now. So blood sugar levels and glycolated hemoglobin are also essential. Before any surgical procedures, you should know the glycolated hemoglobin level, and I'm sure you all know what glycolated hemoglobin is. uh, some patients are, may be prone to have some certain blood hazards, such as, hepatitis B, hepatitis C, and sometimes even HIV. So make it a practice, especially if you're doing a wiring, a dental wiring, or for a fracture or a trauma. Make sure that you have this investigations, triple S, that is HIV, HCV, or HBsAg. We generally write it for any surgery before a general anesthetic procedure. But even for a local anesthetic procedure under local anesthesia, where you expect lots of blood or maybe glove prick, don't hesitate to write this. Okay. Hepatitis, as well as this HIV, is also commonly seen as an occupational hazard in truck drivers and long routes distant bus drivers. Okay, so if the patient is giving you a history of occupation, that I'm a driver and I drive on long distances, truck or bus, then make sure that you have this triple H done. That is my advice to all of you. Uh, Radiographs that we commonly write is the, apart from the IOP, is the panoramic view or the orthopantograph. Orthopantograph again is an excellent modality for pathologies, for trauma, for detecting many other discrepancies of the oral cavity in the jaws, be it the maxilla and the mandible. But one limitation of a panoramic radiograph is that the shadow of the spine basically falls in the mandibular anterior and the maxillary anterior region. So it may not be a very good or an excellent radiograph for in that region. It also can tell conditions like a TMJ ankylosis, as shown as this picture here, an odontogenic pathology, most likely a cyst, as shown in this picture. And then we have this paranasal sinus view. We have this paranasal sinus view. A paranasal sinus view basically is an excellent view which can indicate any pathology or trauma in the mid face or in the upper third of the face. Okay. So in case if you're feeling, if you have a doubt in the mind, the patient has a pathology in the mid facial region, then don't hesitate to write a PNS view. And mandibular occlusal view. Now, if you want to see anything from the, what do you say, from the axial section or from the top, for example, a cylolith, even an oblique fracture of the mandible. Okay, this mandibular occlusal view or a true occlusal view is an excellent modality. So these are the different radiographs that we as a general dental surgeon practice and prescribe. Uh, it is not only about prescribing, but one should also know how to read that radiograph. Okay, it is also essential. So make sure that you know how to read it as well. Now, again, I have a mandibular occlusal radiograph. This is showing expansion. Okay. Now, this expansion generally cannot be appreciated on a two-dimensional radiograph or on an OPG or any other X-ray. But an occlusal radiograph, an excellent modality, if the patient may not afford for a CT scan, then this mandibular occlusal radiograph can depict this how much expansion of the jaw has happened as it happens in many pathologies. So the and also the occlusal radiograph can also indicate the thinning of an adjacent cortical plate, or an eggshell crackling, what we call, whenever the cyst or the tumor expands. Okay, so and then of course we have the lateral oblique view, and then we have the PA mandible view. Now, the PA mandible view is an excellent modality to visualize the mandibular posterior region, that is the condyle and the joints. Okay, it is also one of the excellent modality to all the general dental surgeons who have a patient, suppose, of a jaw injury, maybe a condylar fracture or an angle fracture. A PA view mandible or PA mandible view is an excellent modality to find out or to diagnose a condylar fracture or an angle fracture. And similarly, a lateral oblique view. Okay, so these are all the X-rays that one should know when to write. Okay, when to write and how to interpret. Yeah, and this should be the patient consent form. This is how the patient consent form should look like. It should have the name of the patient. It should have the procedure name. It should also mention what all the complications that can be expected. And then it should be signed by the patient or the patient's relative in presence of a witness. If the patient cannot sign, just have a thumb impression of the patient. So informed written consent, I'm sure you must be having it. And one more thing, make a habit wherever you are using a local anesthesia or wherever you are giving local anesthesia, make sure you take an informed written consent before it. Okay, so this is because a local anesthesia can itself give variety of complications. This is not to scare you, but this is just to make you aware. So make a habit of having an informed written consent, and then have it stored at your clinic. That is also very important. I can show you many cases, many of them published in the national media, like where the dental surgeons have not taken informed written consent, and then the patients are suing the dental surgeons. And we thought probably these are things that happen in the Western countries, in the US or from the Europe. But no, many of the dentists unfortunately have suffered, and uh, as shown in this media news, that the doctor has been told to pay 1 lakh of the patient for a Bosch surgery. So it is informed written consent if you have the patient, and even for complicated surgeries. A videographic consent may also be advised. So it is absolutely important. Okay. A bad time may have scientific value. These are occasions a good learner would not miss. So uh, uh, we should have, we should learn from these. So how do you prepare a patient? How do we prepare a patient? Now this is how you should basically pain drape your patient, and this is the least possible thing which we can have before we are doing a surgery. See, once we are preparing a patient for an oral surgery, we should make sure that we pain drape we paint the patient well extraorally, okay, wherever the surgical site is, and then drape the patient well with a sterile cloth. Okay, so this also would, improve the sterilization, as well as this also would improve the treatment outcome. Having an unsterile field, or having where we are compromising on, where having a conditions where we are compromising on sterilization, may not be suitable for a predictable or a favorable outcome for a surgery. So this is how I prepare my patient. Okay, once we paint the patient, you drape it with a sterile cloth, and this is, you leave the nose. Of course, we leave the nose exposed so that the patient can breathe normally, and this is how you cover your patients till actually the knees with a green cloth. Now, coming to the individual procedures, uh, I'm teaching at one of the government institutions in Delhi, and when my students, when they reach final year or when they are in internship, they always come and tell me, sir, give me a lower eight, sir, give me a lower eight. We want to do lower eights. We want to do impactions. I generally tell them, you manage a difficult, you manage a grossly decayed mandibular premolar first, or you manage a grossly decayed maxillary second molar or a first molar first, because managing difficult extraction probably is the first part of oral surgery. So how do we do it? How do we do it? Now, for example, there is a situation where an improperly treated maxillary first molar requires extraction. Now, many a times, once we try to remove it, you might fracture the crown, and the roots are inside the bone, and you're not unable to retrieve it. And similarly, there's another X-ray which shows a maxillary central incisor with a root fracture, which may require extraction. Now, what I generally teach, and what I'll state here as well, that you should know how to reflect or slate the mucoperiosteal flap after adequate anesthesia. You can also split the tooth. You can also split the tooth with a micromotor handpiece, straight handpiece, or a straight Fisher burr. And if you have not reflected the flap, then probably you can use an air rotor as well. Generally, air rotor is not indicated once you have reflected the flap, because it may lead to an emphysema. Okay, so once we have split the tooth, for example, as shown in this picture here, maxillary molar, we all know, has three roots. Once we have a vertical cut in the anteroposterior direction, and splitting one cut, splitting the buccal roots, the mesiobuccal and the distobuccal roots, we can easily use a elevator or a fine tip instrument to remove one of the root, and then the other two roots eventually will come out. Okay, so we generally also gain alveolar purchase if required, if patient is not opting for an implant. Now, what is an alveolar purchase? Alveolar purchase is basically holding on to one of the cortices of the bone, maybe onto the labial cortical plate or the palatal cortical plate, with a root forceps. Once we are done removing one of the root fragment, you insert that beak deep into the socket, one side, and other side will hold the palatal or the labial cortical plate, depending on what root you are extracting, and light constant pressure is delivered along the axis of the tooth until the tooth is delivered. So this is how we manage complicated extraction case. Now, many of us are doing implants, right? Many of us are doing implants. And this is a new thing which I thought I should discuss with you, the socket shield method. Now, socket shield method is what is socket shield method? This basically is a partial, we also call it as a partial extraction therapy. Now, we all know the maxillary anterior bone, the labial cortical plate, is very thin. And many of us are doing implants for missing maxillary anteriors, or for grossly decayed tooth in the maxillary anterior. We want to replace them. We are putting an implant there. Okay. So just to avoid the collapse of the labial cortical plate inside, we just remove the part of the tooth. We are not removing the entire fragment. The labial part of the tooth is left attached to the bundle bone, to the bundle fibers, and the palatal part is split as shown in the CBCT scan. Now, what it does is it would not collapse the labial cortical plate, making sure that the patient has a good emergence profile and the volume of the bone is not lost after extraction of the tooth. So the socket shield actually improve the buccofacial tissues and the emergence profile, and this is how we do it. As shown in the picture, we use a long burr, a Gates drill, or a long burr to split the tooth into two halves, the palatal and the buccal half, and the palatal half is delivered out with a thin elevator. The labial half, or the labial part of the buccal part of the tooth, is left inside. Okay, so this is how we do a socket shield. It is an important technique to preserve the labial cortical plate or the buccal cortical plate. Staying with exodontia, uh, for dental surgeons who are aspiring to do impactions, I would advise them to start with the easier one first. So we all know that mesioangular impactions are the most easy one to do it. Uh, or where the roots basically are fused, or they are thin, maybe roots which are not dilacerated, roots are short, or roots don't have any divergence significant. Okay, as per the Pell and Gregory classification, you can say that position A, class 1, something like this, as shown in the picture. Slightly erupted with absence of a lock with the adjacent tooth. You just need an elevator on the mesial side. After a little guttering, you can just elevate it, luxate it out, and you can take it out. Also important is that it should not be in close proximity to another important anatomical structures. Uh, Now, many a times, students, especially young students who have just passed out, they come and tell me, sir, we were trying to remove an erupted tooth. It was erupted, it was not even impacted, and we could not remove it. So it can happen. Many a times we can have patients like this, where we have clinically, partially erupted molar tooth which is there, causing pericoronitis or inflamed operculum, giving the patient pain, and we just directly jump onto the patient. Okay, we'll do the extraction, and you'll feel your pain would be relieved. But on the X-ray, if you see, sometimes this X-ray may show you like this. Okay, so it's clinically erupted, but it is going into the ramus. The path of removal is in the ramus, in the ramal bone. So it is absolutely essential to understand the path of removal. If it is in the ramus, if it is distally tilted, or even if it is vertical and there is lock posterior to the distal surface because of the ramus, it is important that you remove that buccal bone, and on the distal surface also it is important that you remove a little bit of that obliteration from the ramus, which is not causing the tooth to be elevated. Okay, so don't be confused by just seeing the tooth in the oral cavity, that okay, it is erupted, I'll do it. It is absolutely important that you judge with an IOP or panoramic radiograph. Otherwise, you are actually inviting a problem. Now, we all are writing cone beam CT and CT scans for the impacted third molars, especially those impacted third molars which are close to the canal. The root apex of those impacted third molars are close to the canal. Now, this was one of the studies which was published in an American journal in 2011, done by me. We tried to analyze five important signs, radiographic signs. Like, one is superimposition of the inferior alveolar canal to the mandibular roots. Second was that diversion or deviation of the canal once they are approaching the uh, mandibular third molar roots. Third is the increased radiolucency between the canal and the roots. And fourth is the interruption of superior radio-opaque corticated margin of the inferior alveolar canal. And last is the narrowing of the inferior alveolar canal. So we assessed these five parameters, and we found out. Now, this study was cited. This has been cited by 65 different personalities, and given me good citations. Now, what we concluded, that the narrowing of the canal and the diversion and deviation of the canal and interruption of the superior radio opaque border of the canal are indicators. So if you have these three radiographic indicators on the orthopantogram, then the chances of injury to the inferior alveolar canal are more. Okay, so even without a CBCT, you should be alerted that okay, this is a case where the patient may have some problem with the lower lip, or a transient paresthesia or dysesthesia. Better to have maybe a specialist coming for me and doing this case, or better to have an informed written consent prior, better to explain the patient. So that is why I put this picture on the top, that the three important radiographic parameters. Now, what can be the frequent complications that can happen with exodontia? One is inability to deliver the tooth. So as I told you, try to section the tooth, section the tooth, and try to remove any hindrance that comes, um, be it anterior, be it in the posterior region. Try to remove that hindrance and try to retrieve the tooth along the path of removal. As in the previous slide, as I was talking about a disto-angularly tilted tooth, it was there in the oral cavity, but it was distally tilted, right? So in case if you're trying to remove it without without shelving out the buccal and the posterior bone on the ramus, okay, you would not extract the tooth. So it is essential. You should retrieve the tooth along the path of removal. Okay, many a times the patient comes out after you are extracted the tooth, the patient will come back with severe bleeding. Okay. Intraoperative also you may have, postoperative. Many of my patients have come back. The first thing with that you do, if the patient with severe bleed which is coming out, or maybe a drip by drip is coming out, make sure that you measure the blood pressure of the patient. Many a times, because of hypertension which goes ignored with many patients, uh, this may remain undetected and cause maybe a cause of frequent bleeding. Now, if it is not in a hypertension, then please make sure you see what is the source of bleeding. What is the source of bleeding, from where the bleeding is coming from, the soft tissues or the hard tissues. Okay, you can pack the socket with this fantastic thing which is called as abgel or absorbable gelatin sponge. It will create localized pressure, and you can just use suture over it. Because of the pressure, the bleeding generally stops. And if you can identify the source of bleeding, if it is from a small soft tissue vessel or a capillary, try to buzz it out. In case if you are having an electrocautery, uh, sutures always help. Sutures over this gel foam will always help you maintaining that, and this gel foam generally resorbs also within some time. Okay, other frequent complications with exodontia can be persistent pain and swelling, anesthesia or dysesthesia or paresthesia. Okay, as I've told you, prevention is always better than having a complication. So you can assess it on the radiograph for the proximity of the inferior alveolar canal and the mandibular third molar root. This actually can avoid anesthesia or dysesthesia, or at least you can inform the patient before. Okay, post extraction trismus is there, especially with the mandibular molar or mandibular nerve block. Generally, it is treated after. You can manage this post extraction trismus by physiotherapy. You can ask patient to have muscle relaxant. You can ask patient to do mouth opening exercises multiple times, 20 times daily. And once the lock is open, the patient is okay. You can also use muscle relaxant for that. In the maxillary posterior region, you may have an oroantral communication or an oroantral fistula, which is a headache actually, especially for a dental surgeon. If he has it in a patient, then it's a big headache. We'll just see in my upcoming slides how to manage it. And then again, one of the grievous complication is accidental displacement of the tooth in the adjacent spaces. Sometimes this is actually true with patients with, where we have an unerupted or a partly erupted maxillary third molar. You try to luxate it, lever it in, and it disappears. It has happened with me as well. So this was one of my student, I think 7 8 years back, trying to remove a maxillary first molar and section the tooth. Two roots are out, but the third root is somewhere lost, and the patient and my student tells me, sir, I cannot see the roots. On the IOPA we can see the roots is in the sinus. So how do we manage it? We manage it by making a small window through the maxillary antrum. Ask the patient to come a little forward like this. Sometimes the root which has gone posteriorly into the antral cavity comes like this. This is also a maneuver. Okay, and once we see the root under a good visible light source, then you can get hold of the root, and as shown in this picture, as we have taken it, we are retrieved, we can do it. Okay, so but diagnosing it is important. Just leaving and just asking the patient to leave, okay, we have done the extraction, and not informing the patient may lead to trouble. It is always important that you inform patient whatever has happened. Okay, we have removed two roots, one root is still there, I don't know, I don't see the root, I need to take a different x-ray, let me see whether it has gone in the sinus or not, or it is still there. And you inform the patient whatever it is. That is what I want to say here. And in case if it is there in your prerogative, then try to manage the complication as shown in this picture. And then we close the area primarily by advancing the flap. Now this was one of my patients where the third molar was, one of the student only tried to lever the third molar, maxillary third molar left side, and see where the third molar has gone. It has disappeared into the uh, antral cavity left side. So the student comes and tells me, sir, I was trying to lever it and now it has disappeared. So again, Again, Caldwell-Leg, standard Caldwell-Leg procedure. You raise the mucoperiosteal flap, make an antral window. You can see the tooth is there, and you just take it out. You just take it out. So you deliver the tooth via this, and this can be done easily under local anesthesia on a dental chair. Now, patient with oroantal fistula or oroantal communication may show you this. See, there is a nasal regurg. This is nasal regurg. Okay, this is what the patient may come and tell you that, okay, whenever I am holding water or having water in my oral cavity, it is coming out of my nose. This is what nasal regurg looks like. Similarly, in another patient, if the patient also complains, may also complains of a discharge, a salty discharge from the oral cavity with a history of traumatic extraction few months back. Okay, now CBCT is an excellent modality. As shown in this picture, we have this coronal view of a CT scan where we can see that this is a buccal cortical plate, this is a parietal cortical plate, and there is no maxillary bone here. Okay, and the sinuses are opacified. The sinuses are opacified. So this is basically a classic chronic maxillary sinusitis, and the infection is oozing out. There is a little discharge from the extraction site also. And the patient was told that the tooth is out, and the patient was sent, and it was referred to me at my institute. So what we do is, in defects such like this, we need to close this defect. Now we cannot actually use some bone here. What we can do is, after control of infection, I'll show you how I'll just explain how do we control infection. After control infection, you advance loco-regional flaps. Here we use the buccal fat pad. The buccal fat pad, the buccal portion of the buccal fat pad, which we have here, everybody of us have abundantly here in the cheek. Okay, so that was advanced and approximated over the defect and closed wire from the palatal onto the palatal mucosa. And then we had the Burgess flap. So this is a two-layered closure. Okay, so this we did a pedicled buccal fat pad advancement as well as a Burgess flap, and the defect was closed, and the wound has healed post-operatively completely. Now, because the patient was also having chronic maxillary sinusitis, please remember that mere doing this would not help the patient, because this may open up also in case if the infection is not controlled. It is always important. So this is an oroantal communication managed by buccal fat pad and a buccal sliding flap or the Burgess flap. Okay, so it is also important in case of a fistula that you remove the lining, pathologic lining, plus you don't forget to give the pre-operative antibiotic course to the patient. Uh, Pre-surgical sinus decongestion protocol, that is, you give some certain antihistaminics, okay, like Sedzin or phenylephrine, and post-operative follow-up, and ask the patient not to blow nose or not to apply pressure in the oral cavity for at least 2 weeks, so that holds on. And this way we can manage this oroantal communication and oroantal fistula. uh, we were talking about impactions. We were talking about roots, mandibular roots, which were approximation of the inferior alveolar canal. Okay, so there are certain newer treatment modalities which are emerging to avoid paresthesia or dysesthesia post third molar surgery. We'll just talk about it as well, because it is under the general dental surgeon's perspective. Change is the law of life, and those who look only to the past or present are certain to miss the future. There's a famous quote given by John F. Kennedy. uh, Coronectomy. Now, what is coronectomy? Coronectomy is basically oral surgery answers to modern day conservative dentistry. That is what I tell my students as well. So now what we are doing in simple terms, wherever you have an impacted mandibular third molar whose roots are in approximation of the inferior alveolar canal, we just remove the crown. We section the crown, we just remove the crown, and we intentionally leave the roots behind. We intentionally leave the roots. We intentionally leave the roots behind. We tell the patient that, okay, we are not removing the roots since they are attached to, or since they are very close in near approximation to the inferior alveolar canal. Trying to retrieve it might give you a lip paresthesia or dysesthesia. There might be some neurosensory deficits. Okay, so what happens within time? Within time, these roots will migrate coronally, as shown in this picture. In a second surgery, if required, you can remove this roots or you can just leave it. Okay, so this basically is coronectomy, and initial studies are encouraging and favorable. And risk for inferior alveolar nerve injury is greatly decreased by this procedure, and there are low incidence of infection also. So you can all practice this in your dental setups. Okay, this was one of the paper which was published by me in the 2 years back. Unfortunately, the knowledge of coronectomy even amongst oral surgeon is low actually, so people are not doing it, but it's a very useful procedure, especially where you are trying not to injure the inferior alveolar canal, and in cases where the roots are in close proximity to the canal. Okay, so there only you will use it. Okay. uh, Now coming to maxillofacial trauma. Maxillofacial trauma can be simple as shown in the upper picture, as shown here in the upper picture, a simple dental trauma, or it can be complex, as this lady has gone a complex trauma of the face. So we are not talking about the picture down, we are talking about the picture which is up, because in a general dental practice we can manage these trauma cases on a dental chair as shown in the picture here above. Okay, these cases are specifically meant for oral and maxillofacial surgeons, so not to venture into it. Now, a simple dental fracture or a dental alveolar trauma in a class 3 fracture, this composite splinting and an endodontic treatment and fabrication of crown will manage this. Okay. Sometimes you have an avulse tooth, we can reimplant it again, we can splint it. Okay, we can splint the avulse tooth, and do an endodontic treatment further. This can manage. Now coming to dental trauma like this. Now this young boy was playing cricket. Probably he had a hit with the ball, and this entire maxillary fragment on the left side till the premolar fractured and shifted medially as shown in this picture. Now trust me, cases like this can be managed at your dental setups very easily. You just need to know how to do a wiring, good wiring technique you should know, and these are very, not very expensive equipments. You have good wire twisting forceps, wire holders, good needle holders, and 26 gauge wire spool. That's it. This is an air charge bar which is easily available in the dental market. Okay, you apply it, you should know how to apply an air charge bar. You should manually reduce the fractured segment, and once you have manually reduced it, just try to do an IMF. And a maxillomandibular fixation after a reduction of the fracture for around 4 to 5 weeks in a young patient should see these injuries off. Something like this. As we had this patient having a dental alveolar fracture in the maxillary left side. This was preoperative and postoperative. Very simply, we have given an arch bar and we have given an IMF, and that's it. Patient is happy, and the fracture has been reduced, and then the arch bar we can remove after 4 to 5 weeks. That is absolutely fine. So these are one set of injuries that you can actually manage on your dental chair very easily, but you should know how to wire. Okay, it is important, and this can be learned on models. Okay, we generally teach our students from the third year, final years, dental graduates. We give them models and we ask them to wire. You do wiring on those models. So by that, you can actually learn it. Even undisplaced mandibular fractures, be it in the anterior dentate fragment or in the condyle fragment or mandibular condyle, can be managed via IMFs like this, as I was talking. But you should know how to do a good wiring. Again, now coming to newer treatment modalities, as I told you, change is a constant. Okay, the change is constant and one has to adhere with it. Okay, so wiring might give you wire pricks multiple times, especially in patients who are having hepatitis, bloodborne disease such as hepatitis C, B, even HIV patients. Okay, and it it takes lots of time. Now there are things called as IMF screws. There are screws which are there in the market which has hole. So we can fix the screws under local anesthesia between the two roots of the teeth and then do an IMF. Okay, the only disadvantage is that you should be absolutely precise with your screw fixation, because sometimes a tooth may have a root which is going obliquely, and in that process you might actually land up injuring the root and causing non-vital teeth. Okay, so otherwise this is a very fast procedure and a very effective procedure using IMF screws. Another important modification with this arch bar, which I happened to learn. One of my good friend and my seniors from Pune, Dr. Chandelier, he actually he designed this arch bar. What he did was, especially he collaborated with an orthodontist. He used an orthodontic mesh. He soldered that orthodontic mesh over this arch bar. So now with that soldering on the orthodontic mesh, this arch bar can be very easily bonded to the tooth surface as a composite. Okay, so you have this composite thing, holding your arch bar, and you may not wire individual teeth. Okay, you just use a composite, and just that, then once you have bonded the arch bar on the upper arch and the lower arch, just do an IMF. Okay, so he used this continuous orthodontic mesh shouldered on the inner aspect of the arch bar. And one more thing, the periodontal status of the patient also improves, because if we are wiring every individual to hold the arch bar, it might be not very good for the periodontium. Okay, once we remove the arch bar, you may have generalized gingivitis. There might be lots of trauma to the gingiva and the soft tissue. So better in case if we can do certain modifications and use this, or use a IMF screws. Now, coming to surgical endodontics, now we are routinely faced with these patients like this, patient having a sinus discharge after an endodontic therapy, patients coming with a discharge from the root apex in the maxillary anterior or in the mandibular anterior regions. So there are different types of flaps in certain situations. For example, if the patient is already having crowns in the maxillary anterior region and an endodontically treated tooth having crowns, all right, and then you are supposed to do a surgical endodontics. So your incision may not be the marginal flap, which generally is designed here in picture A. Okay, because once you suture it, the generally the mucosa will recede, the marginal gingiva will recede, and the crown will be exposed. Okay, that the portion, the gingival portion of the crown will be exposed, and it might not be in a very aesthetic look. So it is better that you use either a semilunar flap as shown in picture B, or a paramarginal flap as shown in this picture C. Okay, and but one sure, because the attached gingiva is very small here, so make sure that you use a 50 or a 40 silk with a thin needle to suture it. The aim of any surgical endodontics, of course, is to remove the pathology in the periapex, clean that area, remove the pathology in the apex, and give a good retrograde filling as well. As shown in the picture, you reflect the flap. This is a paramarginal flap. The defect is localized. Then we do the root amputation. We do a retrograde filling on the root, and then we close it with sutures. Uh, we are using different suture materials, but nowadays we also have biocompatible tissue glue. Okay, we also have biocompatible tissue glue coming in the market. So we are actually doing a study in our institute where we are comparing tissue glue, biocompatible tissue glue, to the suture materials as shown in this picture. Okay, so this amcrylate or this tissue glue can be used effectively. What I have seen is it is effective, but it is a little exothermic. Okay, it is a little hot. And one more thing is that you need to isolate that area well before you use this glue. So this is one advancement that we have in the market, and you should all know it. This is how the radiographs look like. Now, coming to managing odontogenic infections. Now, a carious tooth with a swelling in the buccal vestibule or the parietal side or the lingual side, can be managed easily by extraction or endodontic treatment of the tooth and by extraction. Okay, so these sort of conditions can be managed by, doing endodontic treatment or extraction, or using oral antibiotics with the right dosage. Uh, Conditions like this cellulitis, where sometimes the patient is also compromised on the immune wise, like the patient is having diabetes, and the blood sugar levels are elevated, so you have to take care of that. You have to correct the immune system, do the treatment, do the extraction, do the IND. uh, but patients like this are like life-threatening patients. So I would ask you rather not to venture into these patients, the class 3 patients here, which have massive swellings, and these swellings may actually go into the neck and cause a airway problem and maybe a life-threatening situation. So the cases like this and this, the first and second, can be managed in on a dental setup. Uh, in cases like this, generally you refer the cases to an oral maxillofacial surgeons, and where we need to secure the airway, we also require hospitalization. We need to do x-rays. Now, there might not be a good mouth opening for these patients. So in those cases, we have to do maybe an extraoral radiograph or a CT scans. Blood counts are also important. Do a culture and sensitivity. Now, why culture and sensitivity is important? Because I need to know the microbiology of that. Generally it is, once you have the pus, then it is mostly an anaerobic coverage you require. But better if the patient is already immunocompromised, you always have culture and sensitivity report, and then start with intravenous antibiotics, and also rule out any non-odontogenic causes. Now, many a times I've seen even the general surgeons and other specialities, they drain these infections well, but they forget to remove the cause, that is the offending tooth. Okay, and this is why where we dentists excel. Okay, we don't forget to remove the cause also. Okay, if it is because of a carious molar or a inflamed third molar, mandibular third molar having an operculum, which is infected. So make sure that after drainage, after removal of the pus, after debriding that area, you also remove the cause, or extract the offending tooth. Or if it is a non-odontogenic or if it is of a non-odontogenic origin, please remove that cause. Okay, find out and please remove that. Please treat that cause. I have a small video. I think I will just show it to you on my video gallery. Yeah. Given us some local infiltration here on. I've given some local infiltration here. We're starting with incision and drainage. Now, this is my mandibular inferior border. See this. Okay, this is my mandibular angle posterior border, approximately 2 centimeters below. I was trying to share my screen. Okay. Yeah. I was trying to show a video, probably that was not sharing on the screen, so I'll just skip that part. Hello?
Yeah, you have to stop the slides and then go to the video, doctor.
Okay, so I'll just stop the slides. Okay.
Yeah, yeah. Minimize the slides and
Just a second. Thank you for your intervention. Let me just minimize my slide. Given us some local infiltration here on. I've given some local infiltration here. We're starting with. Is my video visible, ma'am? Now, this is
no, doctor, no.
It's not visible?
No, no, it's not. You have to stop the slide share and then play the video on the slide share, on the share screen.
I'll try it again. Just a second. Just a second. Just give me a second.
Yeah. We can see you on the screen, doctor.
Yeah, and I'm just trying to. Yeah. This is where actually I have to work on my computer skills. I'm sorry. Okay. Angle posterior border.
We can see the video. Yes, doctor, we can see the video.
Yeah, given us some local infiltration here on. I've given some local infiltration here. We're starting with incision and drainage. Now, this is my mandibular inferior border. See this. Okay, this is my mandibular angle posterior border, approximately 2 centimeters below the inferior border, that is here. Now, the skin here is not looking very good. So if I give an incision here, I might actually necrose the skin. So I'm just placing my incision on a healthy part of the skin, which is here, which can actually break up this locule as well as this locule. So I'll start with my incision. It has to be approximately 3 to 4 centimeters in length. See this. See the pus which is oozing out. See the pus which is oozing out. I'm just compressing it. Just compressing it. Yeah. Compressing it. Okay. I've not even gone bluntly now. I'm just compressing it. See how. So I'll just stop the video here. Am I audible, ma'am?
Yes, doctor.
Yes, sir, you are
Yeah, I'll
audible.
just start my screen sharing with my slide right now.
Yes.
So we are back to the presentation, ma'am. I'll restart with my presentation.
Yes. Yes.
Yeah. So what I was trying to tell with that video was ki just a small neck can actually decompress, which the decompress the pressure which was creating the pain and everything, and a small neck. And I generally use my finger. You can use your finger in the submandibular spaces, in the buccal spaces, and try to clear off, and then use lots of irrigation with peroxide, with saline, with oxym. Okay, this way remove the pressure caused and the pain caused, and because of this the patient is greatly relieved. And make sure that you please do a good work profile, that the patient is not immunocompromised, the patient is diabetic, then you take care of that as well. You ask the physician's consultation regarding that, and you remove the etiology. You remove the tooth or the odontogenic cause that is troubling the patient. Now coming to pathology, only benign docile looking lesions should be generally try to treat. You should try to treat on your dental checkup. Aggressive looking lesions, tumors, malignancy should be referred to an oral maxillofacial surgeons. Diagnosis is imperative. This is very important, which I generally emphasize a lot. The diagnosis is very important. Your diagnosis is absolutely essential. And for diagnosis, aspiration, biopsy, radiographs can be suggested to the patient. Now, swellings like this, a young lady who's in her pregnancy is having a fibrous growth on the upper lip. Okay, it is basically a gingival enlargement. This is pregnancy related. So this you can easily remove via a small cautery or even a scalpel. Okay, again a eupulus. Again, a eupulus, a soft tissue growth on the gingiva, gingival hyperplasia. So a small fibroma. These lesions can be, very well removed under local anesthesia on a dental chair. The only thing is you should know how to control bleeding, and you should know how to give good suture. That's it. Okay. Blood, yes, that basic blood profile is important for all patients, which I spoke in my previous slides. These type of lesions will require simple excision, and make sure that you always do a histopathological examination and a microscopic examination after the excision of those lesions. Uh, Lesions like this, where there's a grossly decayed maxillary molar, well-defined radiolucency, and then you have a, grossly decayed maxillary molar with that, and an infected tooth. You extract the tooth, you reflect the mucoperiosteal flap, you enucleate the entire area. This all can be done under local anesthesia on a dental chair. You should know how to do a good closure, how to clean that area, put the patient on good antibiotics. Okay, a good follow-up. That's it. The histopathology here, of course, is radicular cyst, because it is an infected tooth, which is. And then again, now we have a radiolucency as shown in this panoramic view in the mandibular left posterior region, with attached to it's a unilocular radiolucency with a mandibular third molar. And it has to be a developmental origin cyst, most likely a dentagerous cyst or an odontogenic keratocyst, or if the patient is unlucky, the patient may also have an ameloblastoma, or even like this. Okay, so this all will require a small excision, enucleation and closure. You should just know, how to reflect a good mucoperiosteal flap reflection. With your handpiece, you should know how to drill a hole in the bone, take the tooth out, enucleate, irrigate it well, and close it up. Okay. Now, this is one of those interesting cases which also was published, and this has given me citations as well. Not a young, a middle-aged female, basically, with a discharge in the mandibular posterior region, and she's on a panoramic view. We can see a big radiolucency involving the mandibular ramus, and there's an impacted tooth which has been displaced on the left side. There is also a mandibular second molar which was endodontically treated for some time, which the patient told us, but we did not notice that, because this was so obvious. We thought that this probably is a developmental cyst because of the impacted third molars. And as it turned out to be, we gave a differential diagnosis that it is a developmental cyst, maybe dentigerous or an OKC, or it may be an ameloblastoma. We treated the cyst like that only. But to our surprise and to everybody's surprise, that it turned out to be a periapical or radicular cyst. This was because of this second molar which was being treated for the last 10-12 years. This lesion was there. Okay, so this was surprising. We sent this specimen to different labs, one of the best labs, and again the final diagnosis was of a periapical cyst or a radicular cyst. So clinical looks can be deceptive. Histopathological confirmation is always mandatory. That is what I want to say here. Okay, you always do an histopathology of the specimen, whatever you have removed, see it under microscope, you send it to a pathologist, get a good diagnosis done, and then come to a conclusion. As was in this case, everybody thought that it has to be a OKC or a dentigerous cyst or an ameloblastoma, but it turned out to be a radicular cyst or an infected cyst. Okay, and this is the patient post-operatively after 1 year absolutely healed up. This case was again published in an American journal of craniofacial surgery, and again I use this theme: looks can be deceptive. Radicular cyst mimicking a developmental origin cyst. Now coming to swellings on the palate like this. Okay, again this young chap was referred to our department with a problem of swelling in the palate, which was there for last few years. This patient probably went to the dental surgeon first with the complaint that I have a small teeth in the maxillary anterior region. My tooth is very small. Okay, and that time also the patient was having this palatal swelling, but unfortunately for that patient, that I don't know that what the dental surgeon was thinking, he gave the patient a crown and said, okay, this problem is sorted out, now I have given you a crown over that tooth. So the thing was, once we find out that it was basically a deciduous tooth, it was an over-retained maxillary central incisor as shown in this picture, and this is a maxillary true occlusal view. And this, if you can see a radiolucent lesion here with an impacted central incisor which is present. Okay, so this sort of lesions are generally, and there are specks of radio opacity also present within the lesion. So this sort of lesions are generally and this was a solid lesion. We tried to aspirate, but we could not get anything. It was a solid lesion. Upon reflection, we found out that it was an adenomatoid odontogenic tumor, and the patient was managed by this. And again, this case also was published in one of the journals. So a word of caution for palatal swelling like this in the posterior region, because in the posterior region, the palatal swellings without any obvious odontogenic origin can be from a minor salivary gland origin. Okay, we have many minor salivary glands in the oral cavity. We all know that we have 3 pairs of major salivary glands, that is the submandibular, sublingual, and the parotid. But the minor salivary glands, we have around 600 to 1000, which are there all over across the oral cavity. They are there on the palate also. Okay, so sometimes these swellings on the palate, which are hard, and there is no cavity, there's no caries tooth, there is no obvious odontogenic origin, suspect a minor salivary gland tumor, as was this in this case. This was a hard, firm, painless swelling. It was continuous, growing for the last 6-7 years, and the adjacent teeth showed no mobility, but there was no missing tooth or an impacted tooth. There was no carious tooth. We did an incisional biopsy and we found that it was a pleomorphic adenoma of the minor salivary gland. Okay, there might be certain times that it can be malignant also. We can also have malignant variety as the mucoepidermal carcinoma also. Now, we also fabricated a splint for this patient because we were on the CT scan. We knew that it was actually perforating the palate. So post-operatively, after the removal of this tumor, we gave the patient a splint so that the healing went well for this patient and the patient healed up well. So in diagnosis of pathologic lesions, proper clinical examination to check cortical expansion and perforation is very important. We should rule out lymph node involvement, if any. we should try to aspirate from this lesion, and that smear can be sent, if in case if you're not having any positive aspirate, at least those smears can be sent and to a pathologist who can examine on a microscope and tell what it is originating from. Okay, sometimes if you are getting a fluid, then cytochemical analysis can also be done, and removal of offending tooth in case if it is an odontogenic origin is also important. In all cases, make sure that you send your lining for histopathology. In case of suspicious of some malignancy or aggressive lesion, an incisional biopsy is preferred. You do not excise the entire lesion in case if you're suspecting a malignancy. Okay, so aspiration from the cystic cavity can tell you about the variety of cyst. For example, here in the pale straw colored fluid with an impacted tooth is generally indicated towards a dentigerous cyst. Now we can see that there's a label cortical plate expansion. We are aspirating. But sometimes where you have displacement of tooth like this, as shown in this picture here, the inferior alveolar canal is thinned out. Okay, the roots are resorbed. Then okay, it is giving you a warning signal. Okay, you have patients where the tooth is displaced in the paranasal sinuses. Then of course it's an aggressive lesion. Of course, these cases should not be treated at your dental setup. These are the cases which should be referred. One of the cases which we managed on a dental chair, there's this patient with a buccal swelling and a mobile teeth as well. On aspiration, it yielded a straw color fluid, just like the dentigerous cyst, what I was telling you. But here, this is the panoramic view, which shows a radiolucent, well-defined radiolucent lesion with the sclerotic borders in the mandibular body region, and there was non-carious tooth. There was no evidence of impacted tooth, but the tooth which was involved were showing root resorption. So root resorption is one sign on the radiograph which tells you about the aggressiveness of the lesion. So this turned out to be an ameloblastoma. Finally, once we did an enucleation, we used a Cornoy solution also, and this turned out to be an ameloblastoma. One of the another cases, a patient, a denture wearer, an old patient, came with this growth on the lower lip. Now this basically is a varicose. We did an incisional biopsy. It turned out to be a varicose carcinoma, and there were small exophytic growths like this on the buccal mucosa as well. We removed the entire lesion. We gave an overdenture to the patient, which was supported by implants, and the patient is happy. Okay, again, another case which was mimicking malignancy here, which was referred to us again to our department, where the patient was referred by 2-3 dental surgeons. Nobody was ready to do biopsy. They all thought that this might be a malignancy, but there are many multiple root stems also here. One should not forget, and probably this can also be the source of infection, as it turned out to be in this case also. This was a pyogenic granuloma because of this resolved root stems which was there, and we extracted, and this lesion actually disappeared. So another interesting case which I just came across 2 months back. I don't have the pictures of it, but I'll just discuss it. A 77-year-old patient, male patient, who was a prostate cancer survivor and taking biphosphonate, which is denosumab. He undergoes a root canal treatment for the mandibular left canine tooth till the second molar tooth in one sitting, because he was having atresion of the tooth and sensitivity. And till 2 days, the patient was absolutely fine. In the third day, the patient develops deep, intense pain, which was throbbing, which was radiating, which is not localized actually. The dental surgeon was giving the patient ultraset and many other combinations of NSAIDs, but the pain was not relieved. It was only relieved partially for 2-3 hours. And from the fourth or the fifth day, the patient also developed numbness on the lower lip alongside the pain. Okay. And the patient was referred to multiple hospitals. Some did CT scans, some also did MRI. Some said there probably was a nerve injury because of the needle prick. And then finally, this patient was referred to Jamia, to my OPD. See, if it was a nerve injury while the needle prick, the patient would not have a normal course of recovery in the next 2 days. The patient would have numbness right from the time the endodontic procedure was executed. The patient was having numbness after 3-4 days. Okay, 3-4 days, patient was all right. One thing which everybody missed, that the patient was taking this medicine denosumab. Now, denosumab, what is a denosumab? It's basically a biphosphonate. Now, there is something which is very common. It is written or prescribed by orthopedic surgeons, this biphosphonates. This basically are calcium depositing drugs which makes our bone stronger. But they also can induce ischemia, local ischemia, causing less vascularity to the bone. Okay, so in these patients, there is something called as medications-related jaw necrosis. It's kind of an osteomyelitis which is induced by medicines. Now, this patient was ultimately diagnosed to be a medication-related osteonecrosis of the jaw. The patient was treated accordingly, and luckily now the patient is doing absolutely fine. So it is important. But what I want to highlight is to you take the proper history of the patient. You just don't rely on radiographs, CT scans, MRIs. Take a proper history. The patient is telling you the diagnosis. Now, lesions like this, exophatic lesions which are actually proliferating out, fulminating out, fungating lesions are short malignancies. Try not to touch these cases. Maximum do an incisional biopsy or do a referral to an expert oral maxillofacial surgeon or an ENT surgeon or an onco surgeon. Now, malignancies, you can do very easily biopsy punch from this punch biopsy instruments. Okay. I generally use it very conveniently. My students, my residents know that this is my favorite instrument. You just do a punch like this, it will take out a tissue. And one important thing is that you should have an adequate depth of the tissue. See, the size is not important, the depth is important. While taking a biopsy, always remember this. Okay. Now I have this was a question for for once I had an open lecture. It was a question that please identify this famous structure, and on in the crowd nobody could identify it, and it turned out to be this is the inner minaret of Taj Mahal. Okay, this is from basically the inside of the Taj Mahal. Okay, so why I'm showing this is it is absolutely important that just like picture taken from an improper site can give false impression, biopsy taken from a wrong site, if it is a malignancy, the lesion is there. If biopsy is taken from the wrong site, then or improper biopsy can lead to a false diagnosis. So it is absolutely essential that you that necrotic. You try to include some normal tissue also. You try to have a good depth of the tissue. Okay, just not a superficial smear would not help maybe. Okay, the depth is very important. Okay, and try to avoid ulcerative or necrotic tissue. That is very important while doing it. Incisional biopsy. Coming to patients like you can have TMJ subluxation patients, patients who have open mouth, patients who are unable to close their jaw because of an episode where they have opened it once and they are unable to close. So what happens is your joint has actually moved forward and it has stuck ahead of the eminence. It is not going back. So I have a small video which I recorded in my department. Now, if you see the mandible is being deviated to the left side, the midline is being deviated. Move karo, band karo, band karo, move karo, band karo. I can't feel the condylar movements on the right hand side. That means the mandible has been displaced and dislocated and shifted onto the left side. The ideal way to reduce it is. So this is how we reduce it. I'm just showing a video. You press the mandible down with your thumb. You press it down and guide it posteriorly. It will come back. See, it has been reduced. Okay, just like as shown in this video. So why I would like to show this is because many times you are unable to do it. Push the mandible downwards beneath the eminence and guided it backwards. So now we have a properly articulated mandible and the dislocation has been reduced. So this is how it works. Now, we also have patients of chronic head and neck pain in our practice. Now, one should know the different compartments of pain. If the patient is having a musculoskeletal origin, then the pain would be pulling, pinching, and tight type of pain. There would be muscle tenderness, which would be associated. There might be, associated missing tooth from one jaw. And these pains are generally relieved by, hot fomentation, taking muscle relaxants or NSAIDs. Okay. But in case if the patient is having shocking or a current-like pain, then it is neuralgia. I'm treating lots of trigeminal neuralgia patients. Okay, so you should be knowing the difference between a neurologic pain and musculoskeletal pain. And sometimes you also may have vascular pain, which may lead to migraine. Okay, when the patient says, "मुझे ऐसे feel होता है, कुछ pulse हो रहा है," pulsating or a nauseating along with some pressure, then it probably may be because of a vascular origin. So this has to be identified. The difference has to be made and to be treated accordingly with medicines. There are a few medical this thing syncope which is there. Now I'm just concluding my lecture and I'm giving our dental surgeons more reasons why to practice oral surgery there in practice in their routine dental practice. There was a recent survey at Time magazine which concludes that surgeons are on the top spot because they are more practically minded, they possess a high IQ, can remain calm in difficult situations, and the fact the surgeons are likely to be good with their hands was cited as an additional plus. So these are more reasons to be, practicing surgery in your dental practice. My take-home message is incorporating oral surgery in your dental practice is a challenging but a rewarding and an interesting activity. With the knowledge of regional anatomy, which is very important, you should know the regional anatomy, you should get back to your books. Systemic physiology, with the right equipments, clinical support, and confidence, one can venture into it. And the dental surgeon should know where to operate and where not to operate. That is very important. You should know where not to operate. That is very important. You can be a successful dental surgeon then. And this is my faculty where I work, where my operate. It is located in New Delhi. You all are welcome. Like you can visit there. I'm there in the Department of Oral and Maxillofacial Surgery. From the top of my department is located on the fifth floor. Okay, and I get this view from we have a spectacular cricket ground and a sports complex just in front of our department. So I always have this view, and we love cricket and we play cricket on my odd times. This is me playing crickets, and I travel a lot, delivering lectures and going on to conferences all across. So this is my life besides surgery. This is my acknowledgement to my teachers, Professor Gadre, late Dr. Kishore Naik, Professor Shadab Mohammed sir. This is my family and my acknowledgements to my family members. And thank you, wonderful audience, for listening to me. I would also like to thank global dental professionals as well as Gausia madam and our moderator for today for hosting me. Thank you so much.
Thank you so much, sir.
Thank
It
you,
was
Saiba.
actually a very good compilation of many things into one single presentation. I don't think there are any questions because your presentation was pretty clear. But there are a few things which even I have noted down, and even I think that which is not going on in your regular practice, like in our regular practice, but has to be kept in mind. So I would start with the things with the investigations part first, not just the investigations during the procedure or after the procedure, but pre-op investigations are really, very important in the management of the case and planning a proper procedure. And when in doubt, I always advise the doctors to have a case discussion prior and not during the procedure. Some doctors are like they are confident enough of doing the procedure, but when they land up into some situation or a circumstance, then they call up and they are in a pathetic situation that what to do, what not to do. So I would always suggest all the doctors to have a case discussion
Yes,
before starting
absolutely right.
any case wherein there are a few doubts in their mind before starting it.
Absolutely right. Absolutely
And
right.
whenever required, not just the 2D view investigations, but 3D view investigations also make a lot of difference in case planning. And
Actually, Saiba, what
this
I emphasized and I also always teach is you should know basic art of diagnosis. You can always go, of course, with the 3D investigations. CBCT and everything would help a lot, of course.
yeah,
But basic knowledge of reading a two-dimensional X-ray is also essential.
yes,
You
yes,
sometimes the X-ray itself is, see, I'm working in a government institution. Many of my patients may are not
correct,
financially well off. I'm not writing CBCT for each and every patient. Many
yes, yes,
times I'm getting so much of information from even from an OPG or
yes.
a simple X-ray. So my point of view was to, one should try to absorb as much of more maximum information even from the simple X-ray or from the case history also.
Yes, that's what the case planning and the later on procedure. It has to be done in a very well planned way, which not everyone does. But yeah, that is one thing which I wanted to add it up, and also the medical history. Many people miss out on taking a proper medical history when it's
Yes.
a small procedure, very minor procedures. Just like a let it be a filling or a scaling or just a simple tooth extraction. But still, I feel let it be a very minor procedure, maybe a 5 to 10 minutes procedure also. But medical history does makes a lot of difference. which many
Absolutely
doctors
right.
miss out on.
Absolutely right. That
Yeah.
is why I incorporated that slide of, biphosphonate
Yeah,
at the last moment, because I just had that thing. It was just last month only. One of my students only referred that case to my department. Ki, sir, I have done four root canals in single sitting. Patient was fantastic for the 2 days, and third day he developed pain. Fourth day pain exaggerated. Fifth day he has numbness on the lower lip. What do I
yeah,
do, sir? And the patient has gone to big hospitals, corporate hospitals. Everybody is doing MRI, CBCT. Patient is scared. I'm very much scared. What do I do? Okay.
yeah,
So medical history, once I found out the patient is on biphosphonates, it is of course a medication related osteoarthritic necrosis, and I treated the patient. So you're absolutely right, Zaiba, on this, that you should know the
yeah.
medical history and the importance of the drugs.
Yes, sir. And regarding the consent form, like you said, many doctors miss out on this as well. Taking the consent, and just taking the consent is not very important, is what I feel, but also explaining it to the patient. Many a times it happens that we take the signature, and by chance, if something goes wrong, or if there is any other complication which has happened, and patient has already signed for it, but he doesn't know for what he has signed. And many times doctors miss out to explain all the possible complications as well. So I always prefer to explain the patient what properly, like what exactly we are going to do, and what could be the possible complications, and also what is signing for. This also is very important part, which we just give the form to the patient, because most of the things which we include in the consent are more of medical terms, which not every person can understand every single term. So I feel in person, if there is something involved, we have to, make the person aware of what he's signing for and what are all the possible complications.
Absolutely right, Zaiba. Absolutely right. I cannot agree with you more. It is absolutely right. And
Yeah,
one thing which I emphasize to my students always, that be honest to the patient. Be
yeah,
honest. Be dead honest. This can happen. Sometimes the
yes,
patient asks me, "Sir, what are the chances I can have
paresthesia.
I can have paresthesia?" I will advise it. I'll tell ki, okay, I'm traveling on the road. I'm driving on the car. What are the chances I can have an accident? It is less than
Exactly.
1%. It is similarly here. I'll try my
Yeah,
best not to give you a paresthesia, but it
yeah,
may happen. You should know. And nowadays we can also video record it.
yes,
I have known one case where this video recording saved the dental surgeon actually. That is why I
yeah,
emphasize on video recording.
yeah.
So
Patient
that's
information makes a lot of difference, is what I feel. We explain, maybe patient has not understood it well or not got the thing completely,
yeah.
but we have to let them know what exactly it is.
There's a question, Dr. Zaiba. For
Yes,
tick
ma'am.
motor cases of adolescent child, there's a retained deciduous teeth and patient is 13 years. So they're seeking advice from Dr. Imran on kindly give some tips of tick motor cases of adolescent child. There's a retained deciduous teeth and patient is 13 years. Did you get
Yeah,
it,
sorry.
Doctor? Yeah, I'll
Yeah,
repeat. So
yeah.
the
Can you please
question
repeat the
says,
question? Yeah.
yeah, Assalamu alaikum, sir. Kindly give
Walaikum
some
salam.
tips of tick motor cases of adolescent child. There's retained deciduous teeth and patient is 13 years.
You said tick motor.
Yes, that's what the speaker is written. The question person can unmute himself and ask again. It is some Vivo. There's a no name on the
Okay,
question.
okay. I don't understand what is tick motor actually.
Tick motor cases of adolescent
It's
child.
involuntary motor movement of any of the muscles is, I think,
Okay,
is what trying to ask.
okay. So okay. So if it is over retained, and if the patient is you said 13 years, uh, have a neurological expertise on this, whether if the patient can tolerate a local anesthesia, and if the involuntary movements are not up to that mark, that they are hindering the procedure of extraction, then you can, I think, go ahead with the extraction after consent from the after clearance from a neurologist. And in case if it is not troubling the child, like if the tooth is there without any symptoms or any problem, then and if the permanent tooth is also you say in a line, like it has come out permanent tooth, then the patient may retain it till the time it is there. Sometimes you have the over retained teeth which is there, and the predecessor teeth also erupted. The over retained tooth is also there, and it can stay up till it is automatically loosening up and coming out. If it is causing a trouble, I would advise to get a neurological clearance and do an extraction under a local or GA, whatever is appropriate.
I've asked the person to unmute if in case it is, unaddressed. And there are a lot of acknowledgements for you, Dr. Imran. Mr. Sahib Faisal says he's very proud to be your student, actually. So
Okay, Saqib, yes, I can see that in the comment. Thank you, Saqib.
Any more questions?
Any more questions?
Yeah, I would be more than happy to answer a few questions in case if there are any questions.
I think there are no more questions. So from my side, I would like to just conclude by one more point added up to the whole presentation, that pre-op and intra-op care is what I feel is just 20% of the whole care of the patient, but post-op care matters a lot. Anyone can just come, do the procedure and leave, but the post-op care does make a lot of difference in the patient management and also the patient's healing and recovery. So
Yes.
I would advise every doctor to not just treat and send the patient, but also have a look about the follow-up, the possible complications, and have a checkup as well at regular intervals, just to make sure the patient is all fine, and not just let it go, so that later in future any complications happen, it would be under the surveillance of the operated person.
Yeah, absolutely right, Zaiba. And thank you. I would like to thank global dental professionals, Gausia, Madam, Zaiba, all of you to be here. All the
Thank you so
attendants who
much,
were
sir.
there. Thank you so much. We'll sign off.
Yeah,
Yes,
thank
sir.
you.
Thank you so much, sir.
Thank you.
Thank you, ma'am.